is coming. Yeah.
He should. I mean, I can, just leave a message. He should be there.
Okay. I told you.
We have his video also to play. Good evening, everyone, and a warm welcome to all of you on behalf of our current president, Dr. Namrita Sharma, and the CSI executive. Uh, Today, we would have the second session of Kera Grand Rounds of this year. It is a unique opportunity to work with various institutes all throughout these grand rounds. And this time, I'm very happy to let you know that we have Narayan Netralaya as host institute for this particular meeting. And the subject is very interesting. It is allergic eye disease plus diseases. I would like to, at the same time, I would like to, it is why it is unique, because we discuss the cases and they are discussed in a manner which is never, discussed in the mainstream conferences. So it makes it very unique. This concept was started last year. It was conceptualized by our founder member, Dr. Rajesh Fogla, and it was kick-started off by Dr. Himanshu in his presidentship. And we all loved this Kera Grand Rounds. So this is a season 2, which we are continuing with. With this, I would like to introduce our panel for this today's, Kera Grand Rounds. We have this because NN is the host institute. It is headed by, today's Kera Grand Round is headed by none other than Professor Himanshu Matalia, who is a medical superintendent and head of cornea and refractive surgery and ocular surface department at Narayan Netralaya. He doesn't need any more introduction. He is supported by 2 of his, teammates, Dr. Sharon D'Souza and Dr. Harsha Nagraj, who are cornea, ocular surface, and refractive surgery consultants at Narayan Netralaya. We also have 2 more, panelists, Dr. Bhaskar Srinivasan, who is a consultant at Shankar Netralaya, Chennai, and Dr. Nikhil Gokhale, who is working at Mumbai. Both of them are excellent cornea surgeons. And I'm so happy to have all of them here who have significant contributions on this subject. So we are going to have a wonderful time today. With this, I would also like to invite my, another colleague who has worked very hard for this subject, Dr. Nandini, who is a young, enthusiastic, and bubbly, consultant from Narayan Netralaya. Nandini is going to take you through how we are going to have this whole session today. And she has really significantly worked on it all throughout these days, day and night. Nandini, it is all yours now.
Good evening, everyone. Thank you, Dr. Paras, for that introduction on me. And first of all, I would like to thank Cornea Society of India for giving Narayan Netralaya this opportunity to speak on Allergy Plus, which is a very interesting session. And I welcome all the CSI executive members along with our panelists and our audience. So the aim of this session is basically along with the allergy, where we see so many urgent clinical scenarios. So sometimes it creates a lot of dilemma and confusion during the diagnosis and treatment. So we are going to discuss such cases, such scenarios using case examples, followed by question and answers and discussion, followed by a take-home message. So without further delay, I'm going to invite our first presenter for today. He is none other than Dr. Yash, who is working as a cornea refractive consultant at ASD Eye Hospital, Jamshedpur. And over to you, Shabina, to play the video.
Good evening, everyone. I would like to thank the entire CSI team and the panelists for today's session for giving me the opportunity to present my case in Kera Grand Round Season 2, Session 2. I describe a case of a 13-year male who came with chief complaints of itching, redness, watering in both eyes on and off since few months, left eye more than right eye, swelling and foreign body sensation in left eye since 2 weeks. Unaided visual acuity in the right eye and left eye was 6/9 and 6/12. Intraocular pressure in the right eye and left eye was 22 and 17 millimeters of mercury respectively. On examination, right eye showed tarsal micropapillae with tarsal congestion and bulbar congestion. Left eye showed giant papillae in the upper tarsal region along with bulbar congestion and a 1.5 millimeter epi defect with whitish plaque over the cornea in the superior paracentral area with adjacent 2 by 2.5 millimeter loose epithelium with dead cell and debris. On fluorescence staining, both lesions showed positivity. Diagnosis of bilateral recurrent VKC with left eye shield ulcer grade 1 to 2 was made. My plan of action in left eye was superficial scraping over the shield ulcer and the loose epithelium, which was removed with 15 number blade under topical anesthesia. Intralesional triamcinolone acetonide 20 milligram was given in the upper tarsal region in the left eye, followed by BCL in left eye. Topical ofloxacin 6 times and topical CMC 0.5% 1 hourly was given in left eye. In the right eye, topical prednisolone acetate 1% in tapering doses for 6 weeks with olopatadine 2 times for 3 months, CMC 0.5% 4 to 6 times for 3 months, and tacrolimus eye ointment at night for 3 months was given. Patient was followed up every 3 days. On day 6, patient had significant symptomatic relief. The upper tarsal area showed significant reduction in the congestion. Bulbar congestion had reduced. BCL was in situ on day 6. The loose epithelium over here had completely healed. The shield ulcer waste had healed with subepithelial scarring. There was no evidence of any new infiltrate present. Patient was followed up on day 10 and BCL was removed on day 10. And topical prednisolone acetate 1% in tapering doses for 6 weeks, along with tacrolimus eye ointment at night for 3 months, CMC 0.5% 6 times for 3 months, and Olopat 2 times for 3 months was started in the left eye. Instruction to the patient was to avoid eye rubbing, cold compresses, and counseling to parents about the course of disease and need for regular follow-up was explained. Thank you very much.
Yeah. So we are going to start the questions for this session. So I invite panelists to discuss the same. It would be Dr. Harsha and Dr. Nikhil and Dr. Bhaskar. So how do you approach a patient of allergic eye disease with ulcer in general? So Dr. Harsha, can you just comment on this? Like if it is an inflammatory like shield ulcer, so what would be the drug of your choice, like topical steroid, which one you would want to start? And if at all you want to give supratarsal steroid injection, what would be the drug and how do you give? And would you like to also start any systemic steroid? Is there any indication for starting systemic steroid in such patients? Can we have your comment, please?
Thanks, Dr. Nandini. I think Dr. Yash has already, presented a wonderful case. Classically how this shield ulcers present. Talking about topical steroids, my choice of steroids would always be when they come with a acute stage. Would be I always go for a strong potency steroids. low potency, I mean, I just keep it for maintenance doses, but always I start it on something like prednisolone or something. So even when I see patients with this shield ulcer on the first visit, when I do not know if they are steroid responders or not, I always start them only on topical steroids, see how they respond. And then if I only know that they are not steroid responders, only then I go in for supratarsal steroid injections. The reason being this supratarsal triamcinolone, it's known to act over a period of 3 months. And in case they are steroid responders, along with the multiple drugs that we add for allergy, we need to again add multiple anti-glaucoma medications. And there have been reports stating that these supratarsal, sometimes they need to be excised also, if at all, if their responders not responding to the treatment. So my choice of steroid would be a prednisolone acetate, see how they're responding. Over a period of 2 to 3 weeks, if there is no IOP rise, then maybe I might think about supratarsal if they're not responding properly to this drug. And coming to systemic steroids, I give steroids only when it's a known case of AKC or something with involvement of lid margins. I mean, when we have this dermatitis or these sort of things. But alone for maybe something like shield ulcer, maybe I would not start systemic steroids initially. But yeah, I mean, when they have this plaques and all, it's important to remove those plaques to make it heal faster.
It's nice. You covered everything, Dr. Harsha, like whatever. If anybody has any other things to add, you can comment. Dr. Bhaskar or Dr. Nikhil?
So basically, when you're looking at a shield ulcer, you need to know the grading of ulcer. So if you have just an epithelial defect, maybe hiking up your steroids or shifting from a low dose steroid to a more potent steroid with a bandage lens might be able to kind of get you across. You don't have to debride it. But once you have a plaque, you need to debride the plaque. It's not going to settle down without a debridement of the plaque. Again, if you are taking a child into the OR and debriding it, if you feel that the ulcer is a little bit large and you have access to an amniotic, I might just suture in an amniotic and come out so that it kind of makes the child also a little bit more comfortable. For a 13-year-old patient, it's okay. You can do it in the OR, in the OPD itself, debridement, which it's easier for us to manage it in that way. But if it's, say, a 7-year-old or an 8-year-old child, then I might consider giving it. If I have to do it, I might probably not give a tricot in the first instance. I might just give injection dexamethasone supratarsal, because that will act for a couple of days. It kind of brings down my inflammation without me being too worried about a prolonged steroid presence in the eye with risk of glaucoma as such. As far as systemic steroids are concerned, again, it depends. You've given topical steroids, you've put the patient on topical tacrolimus, but the allergic episodes are not settling down. Then you would want to look at systemic medications, whether in terms of steroids or systemic immunosuppression. Again, if you're dealing with a primary atopic kind of a disease, then yes, then you'll probably go more towards a systemic immunosuppression with cyclosporin or tacrolimus, which tends to work well. If you have primarily a shield ulcer variant with giant papillae and you're having recurrent breakdown and you're not able to get the patient off topical steroids and the patient is already on topical immunosuppressants also, then you would want to take a decision whether you would want to go ahead and excise the papillae, because that would also help in reduction of the severity and reduction of the recurrence as far as the number of recurrences that you get with respect to shield ulcer. But that's in a very, very, very small subset of patients that we actually recommend going in and surgically excising the papillae. So it's like, in essence, we've probably done about 13 or 14, and that's been over a last almost 17-year period. So it's not something that we would do right, left, and center. So it's just something that you need to be aware of if you are having repeated epithelial breakdowns, because the scarring in the visual axis will then hamper your visual acuity in a child.
This video was contributed by Dr. Nikhil. Dr. Nikhil, would you like to comment on this subject?
Yeah, so basically, any patient coming with shield ulcer, before we, give steroids or things like that, we need to rule out infection. So this child had come to me with a long-standing shield ulcer with lots of steroids going on. So when I debrided that plaque, if you saw the picture, there was a stromal infiltrate there. So I decided that we shouldn't give steroid supratarsal or anything of that sort. And I sent it for culture, and it had grown streptococcus. And then basically with antibiotic, the the infection has first to be brought under control. So sometimes these shield ulcers may have some fungus there or some bacterial infection there. So here the picture shows that there's a stromal infiltrate. So if you remove the plaque in a shield ulcer, it's basically eosinophilic debris which is there on the surface. Usually the stroma should be fairly clear. And if you don't see a clear stroma, I thought that possibly there's more of possibility of infection. So always rule that out, because once you jump to giving full strength of steroid, if there by chance also any infection. So other things you can look for is, for example, AC reaction. With shield ulcer, you won't get AC reaction. You may not get any hypopion, or you may not get inflammatory picture like that. So keep your thoughts open, and even if you pick up a shield ulcer, rule out infection. That was one thing that is important.
Thank you, Dr. Nikhil, and Nandini, you can move on.
You're mute, I think.
You're mute.
Nandini, you will have to unmute yourself.
Next, Dr. Bhaskar, I think you guys have done a lot of work on giant papillary section. In the time, the work on giant papillary section and mucous membrane graft and all. So by the time I share my screen, can you keep commenting on that? Can you share your experience?
So basically, like I just mentioned, we've done papillary excision in about 13 patients over the last 15-16 years as such. The indications have been patients who've had significant giant papillae with recurrent episodes of shield ulcer, which settles down with topical steroids only to recur and keep recurring again and again. We've not been able to get them off topical steroids. They're already on topical immunosuppressants. We've had to give some of them systemic steroids for episodes of controlling the inflammation. And once they're off the systemic steroids, they again started breaking down. So when we had exhausted all options, we had only two ways to go: either put the patient on systemic immunosuppression or address the local cause in terms of the giant papillae, which is primarily responsible both in terms of mechanical cause and in terms of the immunological cause, because you have a significant eosinophilic accumulations even on the giant papillae, which predisposes the cornea in that area where it comes in contact with two repeated breakdowns. So we had attempted just an excision first way back in 2006 or 7. It recurred immediately. We excised it and applied amniotic. Again, in about 2 months, there was a recurrence of the papillae, because amniotic just acts as a basement membrane, and you have the same conjunctival epithelial cells, the same conjunctival stroma, which kind of grows in, and you end up having the same anatomy. So you end up having a recurrence of the papillae. The next option which was there was using a bulbar conjunctival graft. We did not want to touch the bulbar conjunctiva because these are eyes where you might be predisposed to having to do a glaucoma surgery subsequently. Also, we felt that most of our patients also had a coexistent limbal and tarsal papillae. So we are already, the conjunctiva is an allergic prone tissue in this instance. We were very comfortable using MMG for our lid margin in SJS. We thought we might excise the papillae and use a very thin buccal mucous membrane graft. The rationale being the oral mucosa is more immune tolerant as compared to the conjunctival tissue. The oral mucosa doesn't respond in a similar manner as far as allergy is concerned with respect to the VKC that we see. Third, the anatomy of the oral mucosa is different. It doesn't have the septae that the normal conjunctiva has, which is responsible for forming the papillary excrescences that are mechanically causing the friction on the surface. And the only caveat here is you will have to have a very, very, very thin mucous membrane graft. You don't want to increase the bulk of the lid, which actually becomes counterproductive by increasing the friction between the lid and the cornea. You don't want to increase the bulk of the lid, which will actually start causing a ptosis. Already these eyes might have a mild ptosis because of the papillae itself. So that's again something that you need to be aware of. And in our cases, out of the 13 odd patients, if I remember correctly, almost about 11 after excising the tarsal papillae and replacing it with a mucous membrane graft. It's only in 1 or 2 patients where we've had a recurrence, but again, the recurrences has been beyond the area of the mucosa. So you've had papillae beyond, if you've done a, say, a 10 millimeter and a 5 millimeter wide graft, you've had papillae beyond the mucosa, you've not had any papillae on the area. So we kind of started making a slightly larger graft so that the area which touches the cornea at least becomes much more smoother. Out of the 13 patients, only 1 patient who was a patient with AKC, we had to put on systemic immunosuppression with cyclosporine to control his overall systemic allergic predisposition also. Otherwise, 12 out of the 13 patients, we were able to taper them and keep them on topical tacrolimus without any episode of recurrence of shield ulcer over a fairly long period of time, except for that 1 patient who still had breakdowns, primarily because of his baseline atopic tendency. And here we are basically taking the lid suture and everting the lid. You can use a bit of a contraction to kind of get the bleeding to stop a little bit. You can actually use any of even your entropion clamp to kind of hold it so the bleeding is less. You're trying to, unlike the MMG where you get a plane here, it's a little bit difficult, but you want to kind of peel off and make sure that your surface is bare. You don't want to be damaging the tarsus. You basically just want to be removing the conjunctiva and the papillae. Make sure that your raw area is very well appreciated, because you don't want to oversize your graft. Your graft has to fit within the area of the defect. If you go beyond that, then invariably you will have conjunctival epithelium growing under the mucosa, which will result in a necrosis of the graft. Since these were all children, we prefer to just anchor it to the skin with sutures, and we stuck the rest. You can take a running suture all around also, and secure the mucosa if you don't have access to fibrin glue. If you're using suture on the inner portion, you might want to put a bandage contact lens, definitely, so that the suture ends don't rub on the cornea as such. So the important point here was the fact that you want it to be as thin, and even post surgery you don't really see a bulge of the mucosa. It's absolutely flush. You have to replace the tissue thickness that you are excising. So your tissue thickness is only the conjunctiva and the papilla, and your mucosa also has to be as thin. So it's important to really thin out the mucosa. You can use a crescent to do your dissection. You will probably get a much thinner tissue, just like how we do SICS, but then you will have to use the microscope and focus it on the lip when you do the dissection, unlike the normal way where we actually just do it without using the microscope.
I think we have Dr. Geeta here. So can Dr. Geeta comment on the video? Because it's we have the courtesy from Dr. Geeta.
I think Dr. Basman has very beautifully explained the concepts of mucous membrane grafting for giant papillae. I would just like to reiterate that the mucosal graft that is done for VKC is a little different from what you do for a lid margin keratinization. You don't really have to go up to the lid margin, and the papillae usually begin beyond the lid margin, unlike the lid margin keratinization that you see extending up to the from the gray line. You have to ensure that the graft is absolutely thin. Usually you will have to take posterior sutures, and in a child you always need to make sure that maybe a week to 10 days later you need to remove the sutures, because if you have to get the BCL out and you want to remove the sutures a week after the procedure is done. It, by virtue of the presence of the mucosa, it actually reduces the severity of the recurrences that you see in these patients, because like Dr. Bhaskar mentioned, the oral mucosa is, it responds very differently to an allergic stimulus, and it's not that a mucosal graft prevents the recurrence of the allergic episode. A patient will have recurrences of the allergy, but what you will see is the lack of papillae in the area where the mucosal graft has been placed, and therefore the corresponding decrease in the both the mechanical as well as the inflammatory response and the after effects on the cornea that you see in these eyes. So it's you shouldn't be under the impression that you're never going to have an episode of allergy after you've done a mucosal graft. It is just that it reduces the effects of the allergy that you normally see on the upper tarsal surface, and the overall severity of the allergy significantly comes down. This way, in a child, it prevents and probably prevents you from the need for having to start these children on systemic immunosuppression, and therefore is an important tool that you need to have in the armamentarium of management of VKC.
Would you like to comment upon this, that which would be the best option out of the three, AMT, conjunctival autograft, or MMG? Because all the three have been shown in various reports to be successful for this particular entity, GPCs. Dr. Geeta?
For the reasons that Dr. Bhaskar already mentioned, we would prefer to avoid using a conjunctival autograft. But having said that, I have interacted with Professor Paulo Dantas, who has described the procedure of conjunctival autograft for VKC, and they do believe that they've not had any recurrences with the conjunctival autograft. Amniotic, I would probably think, is something that you want to avoid, because it is something that does not have a long-term effect. But between the CAG and the MMG, for reasons which decrease the overall allergy in these eyes, we would prefer a mucosal graft over a conjunctival autograft. And like you mentioned, considering the fact that the bulbar conjunctiva might need to be saved for a later glaucoma procedure, or for the fact that the bulbar conjunctiva is as susceptible to the allergic stimulus as is your conjunctiva, you might not want to use a conjunctival autograft, and therefore we have a personal preference for mucous membrane over conjunctival autograft. But I do know that there are groups that do conjunctival autograft and claim that the recurrences are equally less with a conjunctival.
There is a question on a Q&A chat box from Dr. Meena Lakshmipati that can we use scleral contact lenses to prevent development of shield ulcer temporarily till the patient is ready for MMG? Maybe Dr. Bhaskar or Dr. Geeta or anyone who has an experience would like to talk about that.
If there is no shield ulcer, but you have a large papillae, you are just hiking up your topical system, or topical steroids, topical immunosuppressants, and that should take care. If you're seeing the epithelium to be significantly stippled and it's almost waiting to break down, and you want to prevent it from shield ulcer, you can use even a normal bandage contact lens. You don't need a scleral contact lens specifically as such. You put a normal bandage lens, hike up the topical steroids, give a short course of systemic steroids if you feel that is going to settle the allergy, and then decide if he's recurring again and again, and the papillae is large and there's stain. When you evert the lid and you look at the papillae, you're seeing staining on the surface of the papillae. That indicates an active papillae. If you just look at the surface of the papillae and there's a smooth surface, just like when you look at your limbal papillae and you see the Horner-Tantas dots, you can see the stippling on the surface of the papillae. That indicates activity, because these are the eosinophilic deposits. Similarly, when you evert the tarsal papillae and you look, if you see the surface is smooth, then it's only the mechanical component which will probably cause ptosis, which will not cause an erosion of the epithelium. But if you're seeing in an active allergy, you will even see the surface showing staining, and that indicates activity. You try to address that and prevent it with a bandage contact lens. You don't need a scleral contact lens specifically for this. You will need a scleral contact lens if you want to correct the astigmatism or the keratoconus or the corneal scar related visual loss that the patient has along with the allergic disease.
Yeah, just one more thing I wanted to mention was that it's not purely a frictional insult to the corneal epithelium. So there is a possibility of cytokines or some inflammatory mediators which are having a toxic insult to the corneal epithelium. So one way of approaching is to put a barrier there, but that alone may not be adequate, as Bhaskar said. So we'll have to treat the inflammation as well. Just putting a lens or something cannot, sort of prevent it altogether.
At this time frame, they feel it's inflammatory more than the mechanical. So if you sometimes, once the disease is cured, you will actually see very large giant papillae, but the eye is quiet. The surface of the papillae is absolutely smooth. So there you really don't need to do anything, because if the eye is quiet, there's no recurrence of the allergic disease. Then the only reason for surgical intervention there would be the mechanical ptosis that the giant papillae is causing, rather than the allergic eye disease itself.
Basically, when we have a papillae in which are active papillae, as Bhaskar was saying, that papillae can be there, giant papillae. Not every giant papillae requires treatment or excision. But when they are active and when they are not responding to your multiple treatment, your supratarsal and those things, then only we think of. So this approach is not a common approach for every patient, for sure. When we talk about any shield ulcer, we are talking about, as Dr. Nikhil was saying, that some inflammatory mediator. Basically, you're looking at a cytotoxic proteins which are there, like eosinophilic, major basic protein, major acidic protein. They're direct cytotoxic proteins. So these are the thing when they come into contact. That's the reason why the shield ulcer has a location which is upper paracentral region, because that's where the direct contact of the papillae is there for a little longer time. So these are direct cytotoxic proteins. So wherever they are in touch with the tissue, it leads to the lysis of the cell and tissue. Hence, if we put a barrier there, well, it's fine that that area would certainly be covered. And that's the reason why when we put amniotic membrane or anything like that, it certainly helps. So similarly, as Meena was saying, that can you put a BCL? Of course, you can put a BCL if you think that you want to buy a time, but it's not just the BCL alone. It's your treatment along with that, what you have given, whether your supratarsal or your prednisolone or whatever you have given, which works. And that's what is going to reduce this thing. The BCL is temporary part, and that's not the one which is going to make and break thing.
In fact, like Manchu, you mentioned, it's always a step ladder approach to the management of these papillae. So sometimes you do have the epithelial situation improve significantly with just hiking up your topical steroids, moving over to systemic steroids, even the cryotherapy that you give to the papillae, and then your supratarsal injection. So it's only after each of these has not worked that you go to the
correct. Along with this thing, I think we have to also remember that unless we take care of the root cause, we're not going to get rid of the allergy. So simultaneously, I'm sure you might have some discussion on those things, but sending across to the allergy specialist to find out what patient is allergic to, finding out possible allergen, trying to get rid of those things would be extremely important there.
Is it a routine norm for you in NN, Dr. Himanshu?
I strongly believe that allergy is a systemic condition, and unless we take care of that thing, we will not be able to get rid of this thing. So my threshold day by day to refer to a allergy specialist has reduced significantly. Having said that, to get a person with good knowledge and get in sync with that can be sometimes a little challenging. But if we find out somebody and we sort of have interaction with them back and forth, it certainly helps.
Thank you. Now we move on to the next dilemma, that is, when we have, how do we differentiate between a sterile, or an immune mediated kind of, shield ulcer or melt in microbial keratitis, an approach to a microbial keratitis in allergic eye disease, whether we are dealing with bacterial, fungal, or acanthamoeba. Is it mandatory to do scrapings? Can I invite Dr. Nikhil and Dr. Himanshu to kind of share their views on that? Dr. Nikhil touched upon that when he shared his video. But Dr. Nikhil, would you like to talk about that?
Yeah, so basically that's what, like I mentioned, maybe Imanshu can add, that we need to rule out infection. So be careful that, infection could very well be there, and it's not very common though, but we should definitely, keep that in mind and rule it out if there is a slightest doubt that there could be a component of infection, and some clinical signs that I mentioned, maybe if Imanshu can add.
Sure. I think Dr. Nikhil has rightly pointed out, starting from sudden onset of lid edema, discharge, ciliary congestion, you have AC reaction, hypopyon, you have infiltrates with cellularity around. These things are startling in your face, saying that there is a microbial keratitis. Whenever there is a stomal inflammation or there are stomal infiltrate, it's always better to scrape than not scrape in these cases. There are all sort of infection microbial organisms reported with shield ulcer, though the incidence may not be very high. But when we get an infection along with these things, the problem is twofold. One is that the inflammation per se, it's a very hyper inflamed surface. Second is the presentation is quite altered. So you cannot always depend upon your clinical acumen here. Whenever there is any microbial keratitis, it depends on three things: how it appears on the cornea. It depends on three things. One, the organism. The organism per se would have certain thing which gives the features of that. Like say, if you have Pseudomonas, which has endotoxin, which is the collagenase, which melts the cornea very fast. So thinning of the cornea, horizontal spread, and all such kind of thing is quite likely there. Whereas gram-positive organism have exotoxin, more localized protein, more hypersensitivity reaction. So the organism per se can have the way it the microbial keratitis shows up. The second part is where you have niche or microenvironment, which includes all the cytokines and all your wandering cells and all your immune cells in the cornea or something. The way they are, that also gives you the typical feature of your individual organism. Like if you have a certain eyes which are altered by their microenvironment, like say if you have post LASIK, post cross-linking, where there is keratocyte rarefaction, where the patient is on steroid or something, the way an organism would show up, it will be totally different. The third thing is your immune response. The immune response is where the thing which we see, we can't see bacteria, we can't see, yes, we can see fungal filaments, but most of the other organisms we can't see. We see the immune response against that. And that's what gives that typical feature. Now, whenever patient is either acquired or induced, topical or systemically immuno-altered, the appearance would be totally different. Now, here in this case, if you see, you have two things which are altered. One, the microenvironment is altered. Second, if they are on steroid, your immune response is altered. So when you see a shield ulcer, and clinically you feel this kind of organism would be little too risky, it's always better to scrape and look for the evidence. If there is any infection, try to treat it. Though it's not very common, but it's always better to be on the safer side rather than on the
side. So you would definitely recommend a scraping of these, ulcers where there is a possibility of an infection, rather than starting empirical management for these cases.
Yes,
absolutely.
Other thing we need to remember, sometimes, you can have low-grade organisms and the patient is already on steroids, and the clinical picture can be quite confusing and mixed up. So that is what exactly I had in my patient, because when you see them on slit lamp and you don't see all the signs of very acute infection. So if it's a low-grade organism, we need to keep our mind open. That's what
that's exactly another thing. I said the three things which so if you involve enough in any of them, any microbial keratitis would not be very easy to clinically diagnose. So our clinical acumen may not be very accurate in these things.
Yeah, and once the infection has started responding, and if it is bacterial, would you like to add soft steroids or steroids to that management after a while in those cases to control
I
the
surely
allergic
would not mind.
inflammation?
I would look at the response. If there is a response, if I have organism, if I have sensitivity, or even if not, and if there is a response, I certainly don't mind adding steroid in the bacterial keratitis part of it. There are reports of fungal and those things. Of course, I would not be very comfortable giving steroid in those fungal. Acanthamoeba and fungal would be, I mean, acanthamoeba a little debatable, but certainly fungal, I would avoid steroids. The bacterial part, I really don't mind starting little early steroids.
And what would be your management choice, mono or multiple therapy for such cases?
So one thing I believe that though the appearance is very weird, but most of the time they do respond to the treatment. Having said that, we've seen that quite many of them are resistant to moxifloxacin, and especially the atopic patient. So be aware of selecting only moxifloxacin as your choice of treatment. I would suggest that if your normal way of treating is monotherapy, then possibly go ahead with that. If it doesn't respond, you can always alter it. But if your standard way of treatment in any microbial keratitis is multi-therapy, I would rather go by that. I've not seen too many of therapeutic PKP required, or somebody who is losing eye following the shield ulcer, infected shield ulcer. That's very interesting that they somehow do respond. So I think I would be quite okay with whatever suits in individual hands.
Sometimes there is an interesting question that, can shield ulcer develop on a corneal graft? We know that there are reports that it can, and we have seen those cases. Would you like to take up this question and elaborate on that?
So same thing as the previous discussion went about the shield ulcer, that the root cause, the battlefield is cornea. The root cause is not cornea. So even if we change the battlefield, if the enemy is still there, it can certainly affect that also. And in fact, even if it's not shield ulcer, the epitheliopathy can be quite bad for any graft. We know that non-healing epithelium or any altered epithelium healing would not be best for the graft.
If I could just add on first.
And there was another, dilemma that
Bhaskar wants to add on something.
Yes, Dr. Bhaskar, please.
Yeah, looking at a PK and a shield ulcer, it's also more important to know you're going to be doing PK probably in a keratoconus or a DALC in a keratoconus eyes. So if your allergy is, you have to make sure that your allergy is absolutely under control before you do it. Again, these eyes, the sutures will tend to get loosened faster. You will end up having epithelial defects in your graft. You might have to be a little bit more proactive in making sure that your epithelium heals. And you might want to, if you're still having your allergy and is not under absolute control post your transplant, that you're worried about the shield ulcer, you might actually consider putting the patient on systemic immunosuppression, especially if it's a PK, because it will help the PK also, it will help the allergy also.
Absolutely.
So we have our next question. Dr. Himanshu, can you comment? Can we do PTK when we are treating shield ulcer? Is there any role of PTK?
Yes and no. First and foremost, we have to see that like first location of the shield ulcer. Where is that something which is affecting the vision? Is it affecting any sort of like leading to any astigmatism or anything? We have to look into that. Second part is also depending upon what kind of shield ulcer was there. Was there stromal necrosis, the stromal melting there? Was there a crater formation? Was there a corneal thinning there? In these kind of cases, PTK may not work as well, because the stoma available is not equal all around. But if it is just anterior stromal scar, almost I would say probably 150 micron is something which I would be quite okay. And if it is affecting the quality of vision, and if you're not, if the patient is not a good candidate for obvious reason of allergy, candidate for a contact lens usage or something, we can certainly do PTK. But if it's like, as you know, that it's a very dense scar or thin out cornea, or I mean, then possibly we are not helping them too much.
Thank you, Dr. Himanshu. So next, we move on to our next case presentation by Dr. Krishnaja. Dr. Krishnaja is a cornea refractive fellow at NN, and now we are going to play her video.
Everyone, I am Dr. Krishnaja, going to present a case on allergic eye disease with microbial keratitis. A 19-year-old male presented to us with a history of decreased vision in the right eye, history of eye rubbing, diagnosed elsewhere as keratoconus with allergic eye disease. Best corrected visual acuity on the right eye is 6 by 12 and left eye 6 by 6 with scissor reflex in both eyes. Pentacam was done, showed keratoconus in the right eye more than left eye, and right eye accelerated cross-linking was planned, which was done, and BCL was placed, steroids and antibiotics were given. On POD 1, eye was quiet. POD 3, complaints of pain, discharge and redness with short clinical history and anterior chamber exudation, microbial keratitis was suspected. All post-operative medications were stopped and microbiological workup was done, which initial smear examination showed no bacteria. Maximum medical therapy was started. On POD 5, patient presented with corneal perforation with increase in infiltrates with 2 mm hypopion. We went ahead and have done glue and BCL. Culture report after 48 hours showed Staphylococcus aureus growth, and we have the antibiotics medication according to the sensitivity report, and have counsel the patient and the parents for the therapeutic PK. On his follow-up, patient was responding well to the treatment, and glue BCL was in situ. But however, patient developed few skin excoriations, for which a dermatologist opinion was sought, and for allergic patch test. Allergic patch test was done, which showed hypersensitivity reaction to Ocupol, polymyxin B, ciprofloxacin, olapatadine, fragrance mix, and nickel sulfate. However, on his, we have followed up the patient regularly, and he was responding well to the treatment. And after the healing of microbial keratitis, we have advised the patient with giving his scleral lenses. Best corrected visual acuity with the scleral lenses were found to be 6/9. Thank you.
Very interesting case, Krishnaja. And here I would like to invite Dr. Bhaskar, Dr. Nikhil, Dr. Himanshu, and even Nandini, because I guess Nandini, this was your case for discussion. So what are the indications for when would you like to treat ectasia in presence of an alert, or when would you like to know what all precautions you would like to take when you are handling those cases?
Yeah. So before I answer that, first thing is about this case, I just want to describe few things what I learned. This case was really a nightmare for me when I saw this case and when I handled, because it was my first case of post-cross-linked microbial keratitis in an atopic patient. Previously, I had seen Dr. Himanshu's couple of cases, so I did had idea based on that and his guidance. I did manage this case. It was a nightmare for me because first the patient was son of a doctor, so they were highly demanding. Second, the patient had a history of atopy. Before he came to me for second opinion on keratoconus, he was diagnosed with contact dermatitis, and he had taken previous treatment for the same. And then he came to me for cross-linking opinion on keratoconus. When I saw him, his allergy was still active, so I gave steroid drops to quiet his eye before I took him up for cross-linking. So after a month or so, during that period, patient developed contact dermatitis again before I took him up a cross-linking. So again, we took dermatologist opinion, and once his contact dermatitis reduced, we changed the drops whatever I gave for allergy. And then once everything was quiet, then I did cross-linking as same protocol as how we do in other keratoconus patient. Once I did cross-linking, next day he was fine, but on day 3 they came with some amount of pain, redness, and the mother was complaining that he is not very much comfortable as day 1. So when I saw him, I think she showed in her in the pictures that we could see a fibrinous reaction in anterior chamber. I did not see a single infiltrate on the cornea, but we saw a little endoexudate with fibrinous reaction. That clinched me that he must be having microbial keratitis. So I immediately stopped the steroid. Though there was no infiltrate, we did scraping, and he was I had kept him on BCL. So that BCL we sent for culture and microbiology workup, and whatever the epithelial edges were there, I could do little scraping on that, and we did microbiology workup. And then I started him on broad spectrum antibiotics, which had both gram positive and gram negative coverage. So I started him on Ciplox, tobramycin, and Occupol eye ointment. So after 2 days, when I saw him, there was central corneal perforation. So that was like the mother was, when I explained the condition, the mother was really not happy, and she was very rude to me that we got surgery with you, with the junior doctor, not doctor, with the senior doctor like Dr. Himanshu was sitting in next door. So that demotivated me, but still I convinced them for therapeutic keratoplasty. I explained the condition. To save the eye, we have to do TPK, but you start the drops, and after 1 day again I reassess. So Saturday I put the glue BCL to secure the perforation, and on Monday morning I called them for therapeutic keratoplasty. But when I saw him on Monday morning, the fibrinous reaction had come down, and the cornea was looking little better than what I had seen on a Saturday. So I told that and they are also feeling, he was, in terms of symptoms wise, he was feeling much better. So to my good luck, I had antibiotic sensitivity report. He was resistant to ciprofloxacin, but he was sensitive to tobramycin and chloramphenicol, and we also do antibiotic sensitivity for linezolid in our center. So he showed highest sensitivity with linezolid. So I started him on topical linezolid. So linezolid, tobramycin, and chloramphenicol, Occupol ointment I started. And since he also had sensitivity to cotrimoxazole, his dad saw the sensitivity, and he himself started him on systemic tablet. So again, patient started responding. After 10 days, I could see that his lid started showing contact dermatitis to whatever the drops I gave. And he was just not tolerating the drops, whatever I was giving. Again, I was in a dilemma, what to continue, how to reduce the dose, but he started responding to MK treatment. So I did convince them to continue the same dose, because I could see little infiltrate behind the glue. So then after a couple of weeks, when the patient was just not tolerant, I personally spoke to the dermatologist to do patch test about the drops, whatever he was using, because I wanted to know what he is getting allergy. So when she did, she told me that he is getting a reaction to the polymyxin, probably to polymyxin B component of Occupol, and ciprofloxacin he was hypersensitive. So we all know that even aminoglycoside is surface toxic. So I did stop tobramycin, I did stop Occupol. I just continued him on linezolid because he did not show hypersensitivity to that. And then later he did well. And one more lesson what I learned when I was handling his microbial keratitis was, like as Dr. Himanshu rightly explained everything, after cross-linking, when we remove the epithelium, that would be a risk factor for causing microbial keratitis. And
So,
these atopy
can I
patients,
interrupt you, Nandini, here? That this brings back me to that question that many of us do not use bandage contact lens post CXL, considering that sometimes we may transfer, the bandage contact lens also may be contaminated. And many of us do patching for 3 days instead of, putting them on BCL. How many from the panel would have an approach like this?
So I would have a little difference of opinion there. if you look at the number of BCL used post PRK, post cross-linking across the world, the incidence of microbial keratitis is minuscule. The same way, if you look at whether somebody is using BCL or somebody is not using BCL, all of us have almost equal number of such kind of cases in our hand, and there's no glaring difference that BCL actually leads to. That's the microbial keratitis part. So I personally don't mind using BCL. I really don't think we can prove there is anything right and wrong here. Whatever suits us and whatever we are convinced, we possibly can follow that. But
what about steroids? Any people would
I start that also. Again, there are enough and millions of cases of PRKs across the universe which are been treated with steroid immediately with epithelial defect created, and they don't undergo melting. So again, I really feel that scare of steroid also is now. Is steroid mandatory? We really can always debate on that. That we really don't know whether you want some kind of inflammation there or some kind of scarring there, or but yeah, I think the steroid leading to infection or melting would be possibly a speculation rather than the evidence.
Would you, Dr. Himanshu, I had a case which I had seen, like, who had presented with infectious crystalline keratopathy post CXL. And she was unrecognized early on because that patient was on BCL and she was asked for a very late follow-up. So would you like to kind of, have these patients for more often follow-ups?
So we just keep BCL for 3 days, just till the epithelial defect heals. It's just like if I have done Thursday, Monday, the BCL is off.
Yes.
So not a long, of course, not a long thing. I would not leave them with BCL. Because one important part is BCL fitting itself would not be the best thing because it's a keratoconic eye. So if your BCL is very tight and it does happen, and if you see that the contact lens is tight, I certainly would not want to use such kind of cases BCL. So if the fitting is not proper, that can lead to tight contact lens, that can lead to more inflammation, and that can lead to corneal swelling and everything. So yeah, certainly not such kind of cases.
Dr. Bhaskar has some comment here.
Bhaskar, you're muted.
You have to unmute on what your last few cases had. So almost about 8-10 years back, we had in SN, we had about 3 patients who developed infection. At that time, we were using contact lenses for all CXL patients, and we had 3. All of them were Staph aureus. And then we said, okay, fine, we stop it and we do patching. Touchwood, the next 10 years, we've not had one. There is a slight difference in using a steroid just in an epithelial defect. Okay, we use steroid for a chemical injury with an epithelial defect. We use steroids for a PRK. We use steroids for other conditions. But when you're doing a cross linkage, you are killing a lot of stromal keratocytes, which in other normal situations don't. So even in an infection, the infection behaves differently. You don't get a normal Staph aureus perforating in 4th day. In a CXL-induced infection, by the 4th or the 5th day, you will end up with the perforation. The advantage that I personally feel with patching is, if I patch the eye and I see an infiltrate or I see an AC reaction, I know it's probably an infection. With a contact lens, I'm always confused whether it's an infection, whether it's a sterile infiltrate. What is it? I feel I still have a doubt. When I'm patching, I know I have sterilized the surface during the CXL to whatever extent. I've put an antibiotic ointment and I've patched it. Then my risk, I would feel that my risk of infection is probably lesser. It would probably be more of a sterile infiltrate if I see. Again, a sterile infiltrate generally starts at the edge of your epithelial defect. Wherever you have the epithelial defect, you'll probably see those whitish dots at the edge and you will have a stromal cellularity. But if you see an AC reaction, you see an infiltrate more in the center of your cornea, then you are definitely dealing with an infection. And in an infection, generally Staph aureus is, at least in the 3 that we had, I think all 3 were Staph aureus.
So Bhaskar, I would just say here that in last probably 15 years or 17 years of cross-linking, which we have done, we would have done probably thousands of them. I can only count 2 infection in my hand, and I possibly Nandini would have one. So incidence is not that high, and certainly, and all of them with the steroid and contact lens. So again, I really don't think I can vouch that this is the best way, or this is the way, or what you are doing is wrong, or what you. I think what we are now talking about what you said, the keratocyte rarefaction. Very interestingly, that's exactly same thing happens in PRK and LASIK. So whenever you do a laser, and that's the area where treated area leads to keratocyte rarefaction, keratocyte disappear, and hence even in a infection following PRK or LASIK, though they are again not common, would behave differently along with when they are on steroid. So, and as you rightly said, both the cases, I had, I think Steph or you saw Steph, I don't remember, it was really long back, but certainly gram positive and behaved like gram negative, and like really was melting the cornea really fast.
Fifth day, fourth, fifth day, all the three ended up with the operation fifth day.
So, yeah. So our next question is the screening for ectasia in allergic patients. Dr. Himanshu, I would want you to comment. So would you like to do screening for every patient of allergic eye disease, or when do you exactly do the screening, and what modality of treatment you want to?
So Nandini, screening for ectasia. So the thing is, it depends on what we are talking about when we call screening for ectasia. If we are talking about a topography, and if patient, if you feel that patient has clinically or subclinical doubt of keratoconus, you have scissoring reflex, you have astigmatism, which is oblique, with best corrected vision is not 6/5, and the frequent change in the glasses or anything, I would certainly not mind doing. I would certainly say not mind. I would certainly warrant a topography or a Scheimpflug-based topography, where I would like to see an early changes also. Having said that, if it's a utopian condition where nobody is paying for anything, and if you are allowed to do topography in every allergic patient, well, that would be the best case scenario. The thing is, when you're looking at normal cornea versus keratoconic eye, the allergic eye disease is in between that. We know that it's a transition point. Many of allergic eye disease may ultimately end up becoming keratoconic. It may be related to the eye rubbing. It may be related to the cytokines there. But it's an interim period, and beyond which would be an ectasia. So from normal to keratoconus, in between where you have something, the features cannot be the same as keratoconic features, because we are tuned to just look for those kind of features where we are seeing clinical ectasia. We have not seen a feature which is specific for allergic eye disease, because there cannot be one, because it's such a beginning of the changes that by the time it evolves into an ectasia, it is a full-blown ectasia. So what we had done, we had studied allergic eye disease. I mean, we studied all their topography, and we subjected them to artificial intelligence, AI-based analysis, and we found out that this is something which there was a difference between normal eye, allergic eye disease eye, and keratoconic eye. But can we define the allergic eye disease pattern? No. So it's not a pattern recognition which we are tuned to, but it was combination of certain higher order aberrations, which possibly clinically we cannot pick and choose. So when we have larger database where many people are doing such kind of thing, we possibly would be able to get these things much more refined, and we'll be able to pick up these changes much earlier. So in ideal situation, ideal world, I would say yes, we should do at least for the data collection purpose, and later on we can. And running AI is not a difficult thing. All such kind of your database, when you run AI, you would be really surprised that there is a significant difference and between normal and these cases.
We do see sometimes reversal of changes post management in these cases if they are in the initial phases of allergy. So it is very interesting that if we have a larger data, probably we would have much more information.
Just one point. Can I?
Yes, yes, please.
Yeah.
Yes,
the
yes.
Only thing is, when you're doing the topography, do it in the quiescent phase, because if you have a lot of SPKs on the surface, your topography, whatever is your topography, is not going to be reliable. You might probably then have to look at the Bowman's topography that Himanshu was mentioning, but your normal topographic data might be not very reliable. So do it once you control the allergy, if you want a baseline for that particular patient. Similarly, if you're going to be doing a cross linkage for that patient, you have to do it as soon as you get the disease under control, and then when you're following up a patient also, your disease has to be under control for you to compare and feel whether there's any progression or not.
For that matter, even prescribing glasses in children with allergy, it's better to do it when the disease is fairly under control. So if you have a lot of limbal inflammation, you'll get change in angle or the power, and so just always do it during a remission.
Bhaskar, what we had studied, what we have published is on Pentachem. So very interestingly, in the Pentachem parameters, many of these parameters, which like non-clinical parameters, when we talking about higher order aberrations and all those kind of things, the combinations, different combinations, when AI takes the different denominators and their combination was very, very significant. So as you rightly said, if your quality of scan is good, and if you're able to get a good quality scan, having a good database would certainly help. And I would strongly suggest that if you have database, please try to compare your database with normal and keratoconic eye, and I'm sure you wouldn't be very surprised that something. And together, when we will be able to pull it together, I'm sure in future we may be able to detect an early ectasia much before it actually becomes clinically evident.
May I just add something?
Yes, Sharon, please.
Going ahead with what Dr. Bhaskar and Dr. Himanshu was saying. So obviously need the surface as regular as possible. So in many of these patients, their limbal hypertrophy, even if it's not active, even once the Horner Tranta spots or limbitis has reduced, they do have a lot of scarring in that area. They may have, of course, pseudoterigmenol is very extreme, but even the scarring or flattening that you see in that area can masquerade an ectasia-like picture, which is why just a placido disc-based topography may not help you that much. So it's good to look at the elevation maps, but of course, in context of everything else. So keep that in mind also, and not overdiagnose an ectasia also. But yeah, red flag always.
Thank you, Sharon. We move on to our next question. There may be some repetitions, but we would like to have opinion of the panel about indications for treatment of ectasia in allergic eye disease. How soon can we treat ectasia associated with these conditions? And risks and precautions to be taken when treating ectasia with allergic eye disease. We can have inputs from Dr. Bhaskar, Dr. Himanshu, and Dr. Sharon. Do we have Dr. Fogla as well here?
Yeah, okay.
You want to go ahead?
Go ahead,
everyone is
please.
fine.
Sharon, please go ahead.
Okay, so as we were discussing even early on in the webinar, it's extremely important to control the allergy as much as possible. Now, why I specifically say as much as possible, because in most of these, we can never really bring it to a normal eye. So we need to have, of course, clinically evident, a quiet eye as much as possible. Also, if they have history suggestive of atopy or any systemic allergy whatsoever, it's a good idea to have, as Dr. Himanshu was saying, to also check them quite rigorously for any systemic associations. If you have a good allergy specialist you have a good rapport with, check that out and then plan for the treatment if you're planning any surgical procedure, because otherwise they can have post cross-linking, delayed epithelial healing, a lot of other issues, recurrence if their allergy is not well controlled and they continue to rub. These are the cases where you can have recurrence of a progression of the KC in spite of cross-linking. So treating them is very important. I just want to highlight one point. So very often one notion of checking IgE is there for patients who have a lot of systemic allergy. But we must remember that sometimes the patients will mistaken and think that they have to treat it once they treat or come for their surgical procedure once the IgE comes to normal. And that is something you need to highlight, that probably it will never come to normal in these patients. Because I've had people who think that 2000 allergy will become 200 and then they will plan. So then unnecessarily will be delaying procedure as well. So try to control it as much as possible before planning any treatment. That's what I would say.
Interestingly, I think we have to remember Demil Gatinel here. So Gatinel, whenever in any meeting, Gatinel would come and he would talk about eye rubbing. And I guess we did have our fun on that part, and again started and kind of thing. But you know what? Now we all realize that direct and indirect eye rubbing is one of the most important factor for the ectasia. Now, as soon as they stop it, and as Dr. Paras was saying, that they do respond. Now, so when we're talking about treatment for ectasia, I think treating allergy and stopping eye rubbing, direct and indirect eye rubbing, is extremely important. That's part of the treatment of ectasia. So if they are treated like this, and if they do not progress, you never know. You may find out that you don't need cross-linking. This is the same reason many times we do come across cases where they have sort of regressed without any cross-linking. We do come across case where because we made them aware of this thing and they stop rubbing direct and indirect eye rubbing. We do cross-linking one eye and we think that other eye is getting affected because my cross-linking, and we give sympathetic cross-linking term or whatever different terms. It may be just Damian Gatinel saying earlier that eye rubbing stop, and it stopped. And that's exactly the point. We are able to stop the allergy and eye rubbing. Well, that may be one of the important treatment for ectasia, and later on required, of course, you do.
Yeah, many times the maps get stabilized and you don't need to treat them for ectasia.
Yes, absolutely.
Yeah. So do we have another slide for?
Yeah, that's what we want to highlight. Few things on atopy, because certain special things we see in atopy. So being atopy, because it's a chronic disease, it do poses a therapeutic challenge. And as Dr. Himanshu said, it is always a systemic disease. So it may not be a bad idea to refer such patients to allergy specialists and start them on SLED therapy if required, so that even that would be able to control the systemic disease and control your atopic eye disease. And what I came across in literature is these atopy patients would have more of a decentered cones. So my only doubt was, if it is too much decentered, should we do a large diameter cross-linking in such cases? Would anybody want to take that question?
Nandini, if we are able to take care of the cross, I mean, if the decentration is in the level of PMD, that's a totally different thing. But usually it would not be very much related to PMD kind of decentration, and it may be a sort of decentered cone. And normally our treatment zone of 8 or 9 millimeter is actually good enough to take care of such kind of thing.
Yes. So, and that's what, as Dr. Bhaskar rightly said, and even in our cases, we had Staph aureus as most common organism, which is a causative agent for microbial keratitis in these patients. So in atopy patients, there are studies which showed that compared to normal patients, like where they proved that it was only 6% in controls, whereas in atopy patient they could see that around 66 to 87% patients had colonization of Staphylococcus aureus. So that could be the probable reason why these patients are more susceptible to develop Staphylococcus aureus infection most of the time. And also remember, in atopy patients, because of that hyperinflammatory immune response against allergy, the T cell lines get used so much that they become deficient sometimes, and even the secretory immunoglobulin like IgA, they would be decreased on your sweat and tears, and those cytokines which usually fight against this microorganism would be decreased. That's why these patients are more susceptible to develop this Staphylococcus aureus infection. This point we wanted to highlight. And and one more thing is, as somebody rightly pointed, there are enough studies to prove that most of the organism which is isolated in such patients, they show most of the studies have shown that it is resistant to moxifloxacin, which is commonly used across the world. So in such patients, we have to be cautious, and we have to use another antibiotic. Like we have been using getafloxacin because it has little broad spectrum coverage from almost 2 years in such patients. So we always start that almost 3 days prior to cross-linking, and once we do cross-linking, we do continue, and only in atopy patients or allergy, we do not start them on topical steroid on day 1. Once the epithelium heals, then we are starting them on steroid, so that we have not had any MK after we have started that protocol. So I would suggest it's better to avoid moxifloxacin in such patients as your post-op regime when you are doing cross-linking. And as Dr. Himanshu was rightly saying, this paper I recently came across, it is from the Dresden group, where they have shown that atopy is a risk factor for them to in patients whom they did re-cross-linking and there was failure of cross-linking. And they did comment that it's the atopy which is a risk factor. As Dr. Himanshu rightly said, yes, atopy would be a risk factor when it is not controlled, and patient would be continuously rubbing their eyes, where the uncontrolled eye rubbing would be a risk. I would call like uncontrolled eye rubbing would be a risk factor for progression in such cases. And what are the risks in such patients when we do cornea transplant? That is what we want to discuss in this slide. As somebody rightly said, because so many mediators of allergy would be epitheliotoxic. So because when the epithelium is unhealthy, that would pose a risk for microbial keratitis, and because of these inflammatory mediators, they would also be more prone for the sterile melts. So with this, we will move on to our next case. So third case is by Dr. Durga. Dr. Durga is our cornea refractive fellow at Rajajinagar branch of Narayan Netralaya. And Shabina.
Good evening, everyone. So I'll be presenting on limbal stem cell deficiency associated with severe ocular allergy. Myself, Dr. Durga Lakshmi Modak from Narayan Netralaya. An 8-year-old female child presented with history of white colored growth in the temporal aspect of the right eye since 10 months. There was no history of use of glasses, but patient gave history of eye rubbing and itching. The perinatal history was uneventful with no developmental delay noted. There was no history of trauma or any chemical injury. On examination, the best corrected vision in the right eye was 6-8 parts and in the left eye 6-6. Temporal conjunctivalization of the cornea was noted extending from 7 to 11 o'clock and encroaching up to the pupillary border with 4 clock hours of limbal stem cell deficiency from 7 to 11 o'clock. Micropapillae were noted in the lower and upper tarsal conjunctiva of both the eyes. Rest of the anterior segment evaluation was within normal limits. Conjunctivalization of the cornea or a vascularized pannus could be seen encroaching 3 mm over the cornea up to the pupillary border from 7 to 11 o'clock temporally with a breakdown of the limbal barrier. Few papillae were seen in the upper and lower tarsal conjunctiva in both the eyes. To stabilize the ocular allergy, we started the patient on topical antihistaminics and topical immunomodulators along with an immunologist consult. The immunologist advised avoidance measures along with a sublingual immunotherapy in case the symptoms worsen. After reduction of the ocular allergy, we have planned the patient for a pannus excision along with a conjunctival autografting with or without amniotic membrane grafting. Thank you.
Quite interesting case here. And can you move on to the next slide, Nandini, so that we can involve the panelists for this?
Yes, I am sharing.
I guess
I'm sharing.
this case was
Yes, I'm sharing.
Yeah. So we have I would like to invite Dr. Sharon and Dr. Bhaskar for this particular, case to discuss. And what could be, we see these cases with various kind of presentations, LSCD, sometimes dry eye, SPKs and all. So what would be your approach for these cases, and for especially for LSCD, when would you like to treat these cases, and what would be your approach? Like, would you like to do a conjunctival autograft? Would you like to do an alloslet, or would you like to take some other technique for these cases?
So basically, luckily for all of us, VKC causing a bilateral limbal stem cell deficiency in terms of number of cases that you would have to treat is limited. So touch wood, you've not had to do a limbal stem cell transplant for a bilateral VKC patient as such. So even if you look at the LVP group, the number of, they've done a couple of Kpros for bilateral limbal stem cell deficiency, they're doing live related, but the number is very small. So it's important to, the reason why it happens is you have the bulbar form of the allergy, which is causing a destruction of the limbal cells. So if you are able to control the allergy before it depletes the entire base of limbal cells, it should suffice, and we would not need to do anything else. Even sometimes when we see a faint limbal stem cell deficiency coming in with early conjunctivalization, once your allergy settles down and you give it time, you will actually see some amount of recovery of limbal stem cell functions also, and a stability of the surface as such. So it's important to control the disease. As far as the case that was shown, if you look at rest of the eye looks absolutely quiet. You don't see any other significant sequelae as far as allergic changes, perilimbal pigmentation, any thickening of the limbus on the other side is concerned. So if this conjunctivalization is there, it should probably settle down with excision and treating it just like a pterygium with a large graft. If you feel that area is large, you might combine it with an amniotic membrane. But your peri-operative anti-inflammatory control has to be optimal. It's more important for that first 1 month, 1.5 months. You want the inflammation to be absolutely under control. Otherwise, you'll end up again with a recurrence.
Yes.
Actually, I mean, a paper from LVPI group had shown that there was chances of recurrence in almost 100% cases where they had just done pannus resection with AMT alone. So, I mean, especially those chronic cases wherein sometimes you have LSCD established, they keep on coming to you for years together, and then they present with a significant amount of LSCD. So, Dr. Sharon, your views on this?
Yeah. So as
disease and it is recurring, and there is a stage 3 LSCD with deficiency, you would probably think doing a stem cell, either a live related or an allergenic would be an option, and put the patient on immunosuppression. The immunosuppression will take care of the allergy. The immunosuppression will survive better also.
Yeah. I wanted to just highlight something. As Dr. Bhaskar was saying, it's very, very important to control the allergy. And as we discussed earlier also, rather than doing a patchwork, we need to try and attack the root cause, because otherwise that patch is not going to last too long. Either the same area will recur, or somewhere else the stem cells will come up. So as we were saying, this of course is a case where it's already developed. The patient has come to us at this point, but very often we are lucky to see them a little earlier. And if the pannus, if it's just an early, we see them as a limbitis or very inflamed area, the vessels have just started growing onto the cornea, as Dr. Bhaskar was saying, with aggressive treatment, we may see some regression. At least it flattens out and gets controlled. But it's, I think, more than anything, for a lot of these patients, the counseling is very, very, very important, because very often they will come to us having met multiple hospitals, multiple doctors. They'll come with a handful of drops, and all those medications will actually be correct in their own way, but it's just that they've not used it for long enough. They've stopped it halfway. They've got dejected after 3 months, 6 months, or a year of treatment. And that whole counseling to explain to the parents, because very often they are children, that we have to just push through this entire few years to try and control it. We'll never make it zero, but we can try to reduce the frequency and severity of the episodes, which will then prevent the damage to the eye in the long run. And that takes a lot of time and explaining, but it's really very, very important, I think, for taking care of these patients, that time and counseling. And of course, the medications, as Dr. Gokhale has so beautifully shown in his work, and all of us are using in practice, that step ladder approach, it works even here. So everywhere, depending on what is the activity in the eye at that point, you take a call on which medication you use. And of course, these are chronic eyes, so we're always adding on usually tacrolimus. Whether we see the activity or not, we are assuming there is activity there. We can't see. As to the surgical aspects of it, as you were saying, just a resection with an amniotic membrane transplant is going to have a lot of recurrence, because we are not sort of replacing what is missing there.
Yes.
We are neither forming a barrier, which the normal limbus does for us, nor we are making any attempt to replace the limbal stem cells in any way. So it is just going to overgrow again. The amniotic membrane is going to be a very temporary solution. So depending on the size and the clock hours of involvement, we can choose to do a conjunctival limbal autograft or conjunctival autograft. And it's important to try and look at the limbus very, very closely, because even if the LSCD is not very visible, if we have to do some form of limbal stem cell transplant from the other eye, maybe, then choosing the site also is very, very important. So trying to identify where you may get a healthy, limbus is also very important.
Yeah, and at times, whenever there is no, active disease process, and it is not affecting the visual axis and not causing any significant morbidity to the patient, probably we can leave it alone, just with the help of medical management. So we don't have to jump to a management for these cases. Yes,
very true. I just make things worse trying to.
Absolutely, points very well taken.
And we have come to the end of the session, and we just want to show a photo. So can you just somebody comment on this photo? What is this? Because we want to give some take home from this photo. That's what.
I would guess that this was toxicity to some glaucoma medication.
Sure.
Probably prostaglandin.
Contact dermatitis.
Contact dermatitis.
Yes. Absolutely, yes. Yeah. So what we came across was this is one of our colleague had given Alcaft for almost 4 or 5 days, and within that he developed this much contact dermatitis to Alcaftidin. So in our experience, we did review our pharmacology data, like those patients who have taken Alcaftidin. Out of 157, I could see that 8 patients had hypersensitivity to Alcaft with such contact dermatitis. So we are not very comfortable in using Alcaftidin. So if anybody has same experience, you can just share.
It's interesting, but I would want to know if your Alcaftidin was all of the same brand, because it could be contact dermatitis to the incipient rather than the molecule itself.
Yes.
You should probably look at that also.
Yeah. So yes, it was from the same brand, not from the other brand.
Very interesting.
So before we kind of, close, we have some questions on the chat box, like on the Q&A box. There is a question about how long can we give tacrolimus and what are the contraindications for starting a tacrolimus? I believe it is topical tacrolimus. Dr. Bhaskar, you would like to give a message for this?
So I've given it. In between there was There was a concern with regarding
Report.
the recurrence of lymphoma in tacrolimus, and then there's been enough literature now to state that we are not really too concerned about it as such. We've been giving tacrolimus for more than for almost about a year also to patients without any issue. You can try to start reducing it. Generally by about the third month or so, I would probably start. I normally start off at 2 times, and then by the third month I get it down to once, and by the 6th month I would probably shift it to alternate days. And generally by another 3 months, I would say, okay, get rid of tacrolimus and let's see how stable your allergy is. Luckily, so far, most patients with tacrolimus, at least we've been able to a large extent, almost 90% of our patients, we've been able to get them off the need to be on topical steroids every second month or third month kind of a thing. So that way it has definitely made, and most patients tend to tolerate it. If they still don't tolerate it, then you can apply it on the lid. But I asked them to first start it with the installation in the eye. Some brands work better. Most patients say Tacliment as a brand seems to be a little bit well tolerated as compared to the others, but there are some issues with the availability of Tacliment everywhere. So then you are left with limited choices, but at least on the skin, everybody is able to tolerate it as such.
True.
See, in the literature, if you just look, there is data that somebody has published 7 years using cyclosporin and I think 3 years using tacrolimus. So those references are there, which may be useful in case there is some medico-legal issue. So we have that much data. I'm not sure whether at what age, but these are in pediatric VKC only.
Yes. I think this entire thing started when US FDA took the note of somebody reporting.
One case report.
The issue was that tacrolimus we are using now, but dermatologists have been using tacrolimus for a really long time. They have really long-term data, and that's something very, very useful for them, and they still keep on using it. So the interesting part is that when FDA kind of organization comes up with a guideline that be careful in pediatric age group and don't give continuously, that's based on their assumption. But in practical aspect, if you look at all those guys, all the dermatologists, everybody is still using it left, right, and center, and I don't think they are worried about anything.
True. And we are almost close to the end of the session. Dr. Himanshu, would you like to have special comments for the session, and then we can just wrap up?
I really don't think I'm a right person to give special comment. Both of you have done a wonderful job, and Dr. Nandini, you've taken a lot of pains to go through all the articles and everything, and all the panelists. We get to learn so much whenever we sit here in such kind of Kera grand rounds. You learn so much. You wish that like such programs are more often than didactic lectures. So thank you.
Yes, it has a relaxing kind of, feel, and everybody is sharing their views casually, and that makes the grand rounds the best, it seems.
Very true. Thank you.
Yeah.
Thank you for a nice
So
evening.
shall I wrap up? We have almost finished in time, kind of, with all, pre-recorded videos. And at the outset, I would like to thank, everyone, especially the presenters.
Just one second. That's one more hallmark of grand rounds, that you have streamlined the pattern in a way that it doesn't go out of hand, and it almost always finishes on time, and that's kudos for that. That's it's nicely you made those format of fixed time presentation pre-recorded, so that there is more time for the discussion part, which we sort of crave for when there are
Thank you for appreciating that, Himanshu, every time. And it is because of a lot of people, like we have a lot of viewership. So I thank all of them for being there with us on Friday evening. Our presenters, who are youngsters and who share their cases with us, very interesting cases, all three of you. And again, the panelists, all of you have significant publications in this field, and that has made this session so much richer. Probably, Nandini, you have one more task. We can, some of these take back home points and maybe circulate that next, in a couple of weeks to everyone through CSI, and that would be much more useful to the consultants and probably residents alike.
I
With
think that's a very
this,
good suggestion, Dr. Paras, that
yeah.
every grand rounds we can possibly sum up those points and then we can circulate so we can have documentation of whatever was discussed. That's a very good idea.
So I'm increasing the burden on the moderators now. And I was also suggesting that Nandini was worried that whether we would be able to finish in time. This topic is such vast that probably we can have sessions on such topics, one after the other, back to back, to cover rest of the areas which were not uncovered today, kind of. So maybe we can look at that later on, and we can, kind of ponder upon that and implement that. With this, I would also like to thank our CSI back office for running it seamlessly, and all our CSI executive committee members for putting in their inputs and their suggestions. And I think thank you very much for being there all the time. And we look
all
forward
the Paras, actually all the CSI content is on YouTube, and I still encourage people to go and see some of our Kera Connects, and even this will be there on the YouTube. So postgraduates and all who couldn't come or who want to see or hear, they can always go there, and it's a very good collection of a lot of interesting material available now perpetually to anyone.
Yes, Dr. Nikhil, very true. So with this, we say goodbye to everyone for today. And it was a nice session. Can we have a group photo, Dr. Shabina, from your side, because all the panelists are here.
Done, doctor.
Thank you. Thank you, everyone. Especially Nandini, a bubbly person. I picked up some lingo from her I interpreted to her. Right. So thank you, everyone. Thank you, Dr. Himanshu.
Thank you. Good night. Thank you. Lovely program.
Thank you, sir. Thank you, ma'am.
Thank you.